It is a real pleasure to be able to introduce Diane Calello. She's a very impressive individual. She's the Executive Medical Director of New Jersey Poison Information and Education System, or NJPIES. She's faculty at Rutgers, New Jersey Medical Center, and is a former fellowship director there. She's served on the board of ACMT. She's board certified in pediatric emergency medicine, medical toxicology, and addiction medicine. And I'm really proud to be able to count her as a valued colleague and friend. And without further delay, Diane Calello.
Thanks so much for the invitation to speak on this topic. As a pediatric toxicologist, I've taken care of patients with lead poisoning for over 25 years, but I think this is a kind of unique lens into the problem of lead poisoning, which is that which occurs in uh, migrants, immigrants, refugees who may have unique sources, but also do have some sources that are common to patients, who are not resettled. So I have nothing to disclose. What we're going to do for the next 25 minutes or so is examine both the common and unique sources of lead in immigrants and refugees. We know that lead comes from deteriorating house paint, for example, but how might that injury pathway be exacerbated in an immigrant child? Um, we're going to discuss cultural barriers as clinicians that we face in treating these patients, and then discuss treatment and why accomplishing our management goals, which is not easy in lead poisoning to begin with, is even harder in these populations. So I'm going to base this talk on 3 case scenarios which we encountered and generated a lot of questions just at the Poison Center in New Jersey, as well as in our clinical practice. So I first became aware of this issue in January 2022 when I got a call from a primary care refugee clinic in New Brunswick, New Jersey, um, that was screening and caring for a family with 6 children from Afghanistan, 4 of whom had elevated lead levels. Um, and you can see here that their lead levels were very significantly elevated. So just as a reminder, a threshold for abnormal as defined by the CDC now is 3.5 micrograms per deciliter. And our threshold for chelation is about 45, but we know that symptoms, particularly cognitive deficits and more subtle neurocognitive findings, happen even at that low level of 3.5, 5, and 10. So these levels were quite significantly elevated. The youngest was a 3-year-old who, is an age where we generally expect to detect elevated lead levels, and that's because they're toddlers and they're, kind of manipulating their environment with their hands and maybe putting their hands in their mouth. And that is a typical exposure pathway, even in the US children. But you can see that even older children in the house were also involved. So, we got to thinking like, well, how did this happen? Where did this exposure come from? Is it that where they were in Afghanistan was a lead hazard environment with warfare and munitions? Or were they living in a lead contaminated home in their home country? Or are there imported food or spices or other folk medicines or dishware that maybe they brought with them? Or is something about their environment now here in the US that they have resettled causing them to have a lead exposure? So we contacted the New Jersey Department of Health, and the investigation kind of ensued from there. And one thing I learned, a little tidbit as we did that, is that for many refugees in particular who are in relocation housing, that is a federal program and may not actually really be included in a lot of the state lead poison prevention programs that we have, and so uh, refugee and immigrant shelters may not actually be lead safe at all. So that's the first case scenario. This is another scenario that we actually face with some regularity at University Hospital here in Newark. So we are part of a biomonitoring program where we obtain lead and mercury levels on all newborn infants and mothers. Um, and that is through the CDC. And we do encounter these mother baby dyads with very elevated lead levels. So here's an example of one, a full term baby who we get that lead from cord blood, and we see that it's a very elevated level and that the mother also has an elevated level. And both are apparently asymptomatic. You know, determining symptoms in lead can be a little challenging because they might be very mild or subtle. But these two patients appear to not have any symptoms at the moment. Um, so we know that the infant's lead is coming from mom because the infant was just born. And we know that lead passes pretty freely through the placenta. But where is mom's lead coming from? Again, it could be something in the migration path. It could be imported goods or food or spices. But it turns out in this mother, we believe the source is that she was eating soil from her home country, um, probably in part because she was anemic and that generated a pica behavior, but also as a cultural practice to try to introduce the baby to soil from her homeland. And it is presumed, because this has been clearly reported, that the soil is contaminated with lead. And lastly, the Poison Center was consulted regarding this 67-year-old male who's now living in the US, but came from Pakistan, who presented to a primary care provider with constipation and fatigue. And his astute primary care doc thought of lead poisoning in the differential and sent a lead level, and then called us when it came back as very high, 146 micrograms per deciliter. And on further history, the gentleman could produce a list of about 6 or 7 folk medications or supplements or Ayurveda that was prescribed by a doctor in Pakistan that he was obtaining um, in the U.S. and was contaminated with lead. So just to back up a second and review what we know to be the regular old modern day sources of lead. Residential paint is still most common, and that's deteriorating indoor leaded paint in homes built before the 1970s. Occupational exposures, particularly to munitions, bullets, firearms, reclamation or recycling of automotive batteries, welding, soldering, other painted surfaces like pottery and cookware, cosmetics, food, folk medications, and of course, water. So I think that water is like a whole other topic, but it does contribute a little bit of lead exposure to many, many people, which does not cause a large magnitude elevation in blood lead levels, but is definitely a source. So when you look at the immigrant or refugee population, some of these sources remain, but with some special considerations. And there's some unique sources. So again, there's the pregnant woman with geophagia. They are folk remedies and supplements which may contain lead either accidentally or intentionally for its medicinal properties. Imported food, like I said, goods, cosmetics, herbal remedies, and jewelry. And then looking at the country of origin, they may be a place where there is still leaded gasoline, industrial emissions, burning of leaded waste, munitions, people living and working near mines, smelting, and then hazards brought about by temporary housing and other impoverished conditions. Here is an example of an interesting cultural source that does come up quite a bit, which is deeply pigmented cosmetics and religious powders. So these products come from Asia, Africa, and the Middle East. I'm sorry, kohl, kajal, and surma, which is the dark eyeliner there you can see, or eye product there, come from Asia, Africa, and the Middle East. And then sindoor, which is this brightly pigmented red powder, also known as vermilion, is a traditional powder used for religious purposes in India, and has also been found to be contaminated with lead. And although we don't expect lead to be absorbed through the skin very much, it certainly is absorbed a little bit and can contribute to lead exposure. Other risk factors for lead, particularly in children, malnourishment. So if you're deficient in certain nutrients, you will absorb and retain more lead in your environment. Age, so younger children. Country of origin. And so it depends on the study and what the catchment area of the particular center doing the research is, but certain countries of origin which have been highlighted as high risk include Afghanistan, Zambia, Thailand, Somalia, the Democratic Republic of the Congo, and then countries in South America as well as Haiti. Country of last residence. So we know that we're caring for people who may have originated in one place, but have traveled through many places through their migration pathway and may incur their lead hazard somewhere along the way and not where they originally started. And then we struggle again, I think, in the US to educate everybody about the different hazards of lead, and that is even more true in a migrant population. So the CDC Childhood Lead Poisoning Prevention Program, as well as the CDC overall, has crafted guidance for screening and treatment of resettled patients in the US, and cites what we know to be a disproportionate burden of lead in these populations. Here are the screening recommendations for all newly arrived refugee children and pregnant and lactating patients, recommending essentially screening everyone under 16 years of age and over 16 if there's any index of suspicion, and then screening all pregnant women and pregnant and lactating patients. And then there's some follow-up screening guidelines as well. So I think the take-home message of this is they should all be screened at least once if they're children and women. Again, in a general sense, the clinical effects of lead poisoning, just to review, we know it's a neurotoxin and a blood toxin primarily. So it impairs heme synthesis, causes elevated precursors of heme, including things like erythrocyte protoporphyrin. We always talk about it causing basophilic stippling on the smear, and you can see these blue dots on the CBC, on the smear. That anemia triggers things like pica, as well as we see GI symptoms. Lead colic is a pretty severe abdominal pain syndrome. And then neurotoxicity, which in adults may include a motor toxicity, some cognitive dysfunction, and then of course in children, even in the very low levels of exposure, can cause intellectual decrement. So even small amounts of lead have been demonstrated in populations to show a decrease in IQ and other cognitive outcomes like reading readiness or impaired speech, language development, and delinquency, conduct disorder, and criminal behavior in adults. So that's not unique to the migrant population, but it is yet another thing to be concerned about. And diagnostic testing as a presumptive measure, while you're waiting for a lead level, you might see lead lines, which is this metaphyseal enhancement. Lead impairs bone remodeling. And so what you're seeing here is actually not lead, it's calcium, but it's altered bone growth. And this is seen on long bone films. And then in some patients, as we did see with 2 out of those 4 Afghani children, you might see a lead burden in the gut if they are in fact eating lead and are not just exposed to particulate dust. And so these radiopacities here are lead in the intestines. Very quickly, what do we do to treat elevated lead? First and foremost, we remove from the source. And there's nothing that we do that's as effective as removing from the source, other than prevention in the first place. But obviously, the cat is out of the bag. So, removal from the source, if the source is your home, is hard, no matter who you are. But if you have no place to go, it's even harder, of course. But if a child or an adult is living in a lead contaminated environment, that really is the cornerstone of treatment. If there's a heavy lead burden in the gut, we might do GI decontamination with polyethylene glycol. We try to do that before chelation, but if we're using an oral agent like Succimer for chelation, we might go ahead and just do both at the same time. Replacing the nutrients that might be deficient with specific focus on iron and calcium. And then, like I said, chelation, if the lead level is over 45. In children, the threshold is a little higher and a little less concrete in adults, but essentially, if there are problematic symptoms, or if in pregnancy, we would probably chelate right at 45 as well. So let's talk about some reasons why that little management strategy is hard, particularly in resettled patients. So for this family, it's determined that the source of their lead is actually their relocation housing in the US. And the children, who are also anemic, are eating leaded paint chips inside the house. So they are admitted for chelation, but now they need new housing. And the temporary housing that they were in was hard to come by in the first place. Sorry. For this mother, talking to her about, again, chelating is not really the barrier here, but what is the barrier is she's not really wanting to talk about having eaten this dirt from home or this soil from home, and yet is very attached to the practice. And so overcoming that deeply held belief while not stigmatizing the patient is a challenge. And lastly, this gentleman, who just parenthetically did not like us very much, was just does not believe that the supplements that he's taking contain lead, despite a fair amount of research demonstrating that that is really very likely. So, he wants to continue to take them and doesn't really trust the medical experts who are weighing in on his care. So barriers that we always face are things like medication shortage for chelators, the palatability of those agents. Succimer really tastes terrible. It's hard to convince anybody to take it, particularly children. And the fact that lead poisoning is a bit of an invisible illness, right? The symptoms, particularly in children, are almost not there until you discover that there's a cognitive deficit. In addition to these, though, in the migrant population, a language and health literacy barrier is often present. The extreme stress of relocation and fleeing their home plays a factor. There's, of course, a lack of insurance, adequate housing, and support. Patients just may distrust providers who don't speak their language and don't understand their journey. We are coming up against deeply held beliefs and cultural practices, and patients may be reluctant to really let those go. And lastly, patients in this population have a lot of fear of deportation, of prosecution, resettlement, and violence. So all of this makes an already difficult to treat disease harder to treat. So to conclude these cases, these children were successfully chelated with oral Succimer in the hospital, and fortunately housing was able to be secured through the local and state health department lead poisoning prevention programs. They were able to get involved once the case was kind of called into the poison center and triggered state lead poisoning prevention resources. However, they continue to kind of rebound their lead levels and continue to be in care for lead poisoning, particularly the two older children who really had a very refractory pica habit. So this case is ongoing. This mother-baby dyad underwent succimer chelation. Um, as an aside and another topic, that can be done in infants, although it is challenging, but we were able to just basically provide it through syringe feeds to the infant. Mother reported stopping the pica behavior, and then on follow-up, the lead level had fallen. Again, we do expect, I think, with a long-term exposure, for there to be some rebound of the lead level after chelation, and we did see some rebound in this mother as well as the baby. But we're continuing to follow, and they have not needed another course of chelation. And of course, the infant is referred to early intervention to determine, as the baby gets older, if there are any neurocognitive deficits. And this gentleman underwent IV chelation with EDTA in the hospital, and was able to be discharged. His symptoms of constipation and fatigue, as well as some abdominal pain, did resolve. And he says that he has stopped the supplements, but is trying to get them tested formally just to confirm what we said about it being contaminated with lead. So, we know, like I said, that a lot of supplements are contaminated with lead and may even be used for medicinal properties, quote unquote. So we believe that to be the source. And so far, he's doing well. All right. So in conclusion, we know these populations face novel sources of lead poisoning, but they also face some common sources of lead poisoning. They do have some unique and common barriers to care. And I'll just make one plug for maintaining a high index of suspicion when caring for these patients, because a lot of the symptoms of lead poisoning are vague, right? It's abdominal pain, it's fatigue, it's anorexia. Maybe it's a child who's like a little hyperactive, but they just migrated from their home country and it's been a chaotic few months, right? So these are vague symptoms. And the only way really to know is to get a blood lead level. So bear in mind that the CDC recommends universal screening, but also that the only way to diagnose lead poisoning is really to think of it. And these patients really are at a much higher risk. So I thank you for your patience. I think I finished a couple minutes early, actually, but we've got some time for questions.
Great. Thank you so much. That was wonderful and very, very relevant talk. I will say, as Diane and I were speaking, we're thinking, how can we fit toxicology into the theme? And I think it's a perfect example of how we need to think outside the box, right? So many of these symptoms can present very vaguely, and thinking about the conditions in which the patient is coming from, their community, their culture, very, very important. And so thank you very much. That was very, very helpful.